Welcome to the Voices of Healthcare Equity. I'm Kim Tranquata, founder and CEO of Healthcare Alliance for an Equitable World, and your host on this journey. Our organization, driven by clinicians, is on a mission to address global healthcare inequity using telehealth solutions. Together, we're building a community of healthcare professionals committed to making a scalable impact on global equity. Join me in insightful conversations with global health innovators as we explore the current and future state of healthcare. Be a part of the mission. Let's create lasting change together. Today, it is my pleasure to introduce Dr. Nondumiso Makhunga Stevenson. Nondumiso and I met through our mutual participation in the Entree MD Business School and connected around our shared interests in global health equity. Dr. Makhunga Stevenson was born, raised, and trained as a medical doctor in South Africa and is currently obtaining a PhD in medical immunology. She has extensive experience working on projects with multinational organizations such as USAID, CDC, Global Fund, World Diabetes Foundation, and the Bill and Melinda Gates Foundation. She has recently located to the United States, where it was my good fortune to meet her in our Entree MD Physician Business School. Welcome to the podcast, Nondumiso.
Thank you. Thank you so much, Dr. Kim, Dr. T, for inviting me. It's really a pleasure to be here. I'm excited to talk about our mutual interests around global health.
I am also very excited. Before we begin our conversation, I always give our esteemed guests the opportunity to have any affiliate disclaimers or need to identify any conflicts of interest. Is there anything you want to say before we start?
I have no conflict of interest.
Thank you. So let's get into it. We're going to have a lot to share. You have a rich history in global health. Please tell us a little bit about your background and how you came to be involved in issues of health equity and global health.
Thank you. And again, I'm really excited to share my journey with you around global health. And as you mentioned in your introduction, I'm a South African. I was born in a township just outside Durban called Umlazi. At the risk of giving you my age, it was well within the height of apartheid. And so something that has really dawned on me more recently is my professional journey and even my personal life has really been marked by the paradoxes that I saw. I say that because I come from a medical family. My father was a doctor and my mother a professional nurse. And for the group race classification that we were, one would have considered us relatively well off as a result of that. So my childhood was basically very different from the typical African child at that point, in that my parents could afford to place me in what was called private school, which were multiracial schools at that time. So those schools, because of the Group Areas Act, were in the suburban areas, predominantly white areas. And so you would go to school and see a modern society, well-resourced, good infrastructure. And in the evening, you go back to Umlazi, with all the challenges that were there because of the political system at the time. So for me, I think that really shaped the way that I view the world, just being always aware of discrepancies and disparities. And as I said, throughout my career, I've always taken note of that, perhaps more than other people. And why I say that is that even my children, are at a point where they make those types of comments that, Mom, you always see this difference, in everything, whether it's access to education, as the recent conversation that I had with my son, who's now at university, really lamenting the process for applying to university and how it was expensive, how the probably very inaccessible for a big part of our society. So that's essentially where I grew up. And as I said, being from a medical family, and both having Western trained and traditional healers in my family, I think it was natural for me to be inclined towards medical school. I loved it. I can't remember a time when I really did not feel that I wanted to go to medical school. And I had to work very, very hard because I felt that was my calling. And I was very fortunate to attend the same medical school that my father had attended in Durban, which was the University of Natal, now called the University of KwaZulu-Natal. And that was when I started also only for Black medical students, but very proud to have had the type of education that I received there as a doctor, because the type of educators and doctors that we trained under were very mindful also of disparities in our society. And they instilled that in us to always look, and understand the patient's circumstances holistically in order to be able to manage them well. And many of them were also very politically active and were anti-apartheid activists at the time. And so that was my journey, really, of how I became a medical doctor and what has really been internalized in terms of global health. And that's what's characterized my journey in the medical field.
I don't want to shy away. I want to lean in a little bit to this topic and this conversation with you. I would love to talk a little bit more, because our audience is multinational, right? And not everybody understands the perspective of someone living as a Black person under apartheid. You talk you give us a very clear history of how your experiences as a person that is in a marginalized, what you call outgroup, will carry not only the challenges, right, but the weight of that perspective and how that brings you into the world with a different lens than people that are in a majority group and cannot, and the things that you see that they do not see, and how that has shaped the person you've become. So I wonder if we can just lean into that a little more. I would love for you to, what you said, you would go away to your private school, and of course you understand that was a privilege that came with you being of a different economic status. But here at a young age, as a parent, we tend to shield our kids from these social, political things, but that is also a position of privilege, right? Some people can't shield their kids from those things. They're living in it. And perhaps that's not so. First of all, apartheid is bad. I don't want to say it's not bad. Racial inequity today is bad. Everything is bad. But how that awareness shapes the very mature perspective you have as an adult. What did you see when you were a child? Here you are, you're a child, you're going to school. You're a little older, but you're still a kid. You're going to school and you're seeing that you can go to private school. Your friends in the neighborhood can't go to private school. The neighborhoods you're going through look like this. People are able to do these things and your community cannot. people maybe refer to and relate to each other a certain way at your school and at home. Tell us a little bit about that.
It's something that one really gets to understand and reflect on much later on in your life, right? So while you are still growing up, it is just your reality. And I think it was only when I got to high school. So I also attend a private high school, which is one of, it's a prestigious high school in South Africa. And now you start living with people from all walks of life, including students who were from outside South Africa. And some of them were African students, perhaps from Botswana, from Lesotho, from Swaziland, who did not have apartheid laws. And you start to see sometimes how difficult it was for them to adjust, because where they came from, they didn't have that. And we had a certain understanding about our situation. So looking back, you start to have this awareness. And again, I'm sharing my age with you here, but in 1990, when Nelson Mandela was released, I was in my final year of high school. And this is when I really saw that we didn't really look at, the country or the social structure of the country in the same way, because the response to the announcement that he would be released from prison, it really, gave such surprising responses, and at the same time, I now understand also a little bit better the power of propaganda and media and access to information that people might not have had. But for me, I really observed that, we didn't really look at it the same way. And people, like you mentioned, have been shielded from the realities of these circumstances and these situations, especially people in the upper echelons of society, perhaps to some degree because it's what we want to exist. The status quo is comfortable for us. But for me, being in that situation and going back to my home during the holidays in the township, at times there were some periods of intense violence, and, you kind of observing the world from two lenses. And that, again, as I said, it really made me look a little bit deeper at societies in general. And this pattern kind of repeated itself in my medical journey, because I start to interact with patients when I was in my clinical years. From about third, fourth year, we start doing ward rounds, and you start to hear stories from patients about difficulties in getting to the health facilities, challenges with having meals, to take the medication. And these are situations that are very distant from what you might have experienced, because you've grown up, there's a car, and, you've never missed a meal, in your life. And of course, there were many Africans in a similar situation, but you really are now faced as a doctor with the harsh reality that you have to be more mindful about the circumstances that your patient comes from, because it's not just as easy as writing a prescription for medication, writing a prescription for insulin, and yet the patient doesn't have a fridge. What are you expecting? They don't have a meal, they don't have running water. So all of those aspects become very, very important when you are managing the patient, because it calls on you to remove yourself from your own personal bubble what you know, of what life is like, and put yourself in the shoes of the patient to be more effective and to be much more creative in how you can counsel the patient, as is our responsibility as doctors. You don't just prescribe the insulin and leave it there. You don't just prescribe medication and leave it like that. You have to educate the patient about lifestyle and, such situations. So medicine for me was very much eye-opening, because it brought me much, much closer to the realities of people who were less privileged and people who lived in underserved communities in terms of healthcare. So that's how that paradox found expression in my career. And I can share with you, through the years, how I've been in those situations. But I do feel that and believe that it has really made me a much better doctor, in the sense that I'm much more empathetic because of that understanding and because of that insight that I have about these inequities in society.
Thank you for sharing that with us. It really makes me think about what are the lessons that we want the future generation of healthcare community to take away from apartheid, from many of the social movements that are going on today in the United States and elsewhere, about the importance of being an advocate and not just being passively aware on the sidelines. Here in the US, we have a lot of burnout in medicine. And some of that is around the helplessness and the feeling of frustration that healthcare professionals, doctors, nurses, are feeling around all of those social and political inequities being a part of the medical care they're able to provide. And the solution isn't just to passively withdraw. At some point, you have to move yourself from being a witness. Witness is important. It is the first step in empathy with our patients. But you do have to move yourself from being a witness to at least an ally, and ultimately empowering yourself by being an advocate. What are your thoughts?
Absolutely. I agree. I agree with you. And it varies from person to person. And like what I hear from what you're saying is also working within an individual's strengths and what they are comfortable to do. You often think about the situations, especially when I was a junior doctor working in the hospital, of that same helplessness. When I think about, my intern years, they were at times very, very traumatic, because that was the start of the HIV and AIDS. I don't even know what to call it. Catastrophe really is the word, where you find yourself crying in front of the patient because you couldn't save the baby. At one point, I was considering becoming a pediatrician, and the parents are comforting you as the doctor because you are crying because you could not save the child. That is the day that I realized that there's no way that I could be a pediatrician, because this is now our daily work, you know. The same when I was in the adult ward, you find yourself admitting patients, working hard on call the whole night, and the next morning your round is you doing death certificates, you know, because of AIDS. So those are some of the traumas that we go through, or we went through in any case, as young doctors, fresh out of medical school, bright-eyed and bushy-tailed, thinking we were going out there to save lives, only to be confronted by all these structural issues, you know, whether it's in pediatrics, maternal mortalities. Those are all some of the issues that you start to understand the impact of the environment, you know, the social and the political environment. And I can definitely relate, and as I'm sure many doctors can, to that helplessness when you're working in a resource-limited setting. But I was so excited around 2004 when there was availability of antiretrovirals in the country, because then you started to practice medicine in a much more meaningful way. You know, you would see a patient who is severely ill being, you know, wheeled into the ward, and, you know, sometime down the line, maybe a month later, the person is walking out, they've gained weight, they look healthier, you know, you've treated their TB. So that understanding for me also came that political will is very much a big part of what we need to see in order to change, to see the change, you know. Yes, as doctors, we can be witness, we can be allies. And allyship also means having the awareness, but also knowing the resources that you can pull on. So, you know, we have to understand the multidisciplinary team that we can lean on. So it's not just being an ally on your own, but, you know, what is the role of the social worker? What is the role of the psychologist, you know, in supporting patients? And you'll find that when you have that type of team and you make those connections with other healthcare providers, you can usually work a little bit better. You can have a little bit more traction in terms of supporting the patients. Even, non-governmental organizations, faith-based organizations. For me, those I have witnessed and I've seen how very critical they are to helping you if you choose to become an ally. You don't have to do it on your own, you know, to do that. But yes, empowering yourself is a very significant part of it. Knowing the circumstances that your patient comes from, listening is a key attribute of being part of the solution. Being non-judgmental is a key part of it. Later in my career, I worked with key populations, patients who are at risk of HIV acquisition, high risk of HIV acquisition, which was mainly sex workers, men who have sex with men, and people who inject drugs. And that's when I really, really got to understand the power of not being judgmental and the power of listening if you really want to be part of the solution. Because if you are not familiar with that situation, there's no book that will help you understand it better than somebody for whom that's the lived experience, So whatever way that you want to interact, whichever way that you want to help and be and have a meaningful contribution, listening is a very, very important action.
Thank you for really letting us go into the past and talking about some of those issues. I didn't want to just skirt those issues. I know people say them and then they don't talk about them. It doesn't help people gain perspective. It doesn't help to forget the past. You actually have to remember the past. You have to analyze the past in order to bring the lessons out of the past. I hear you talking and I think about how much the AIDS epidemic was mirrored in the COVID epidemic and how it felt like we had not learned anything. We, in the AIDS epidemic, made excuses for why it was only a certain group of people and we didn't have to pay attention. And somehow that would shield us from this issue. And just having to watch it evolve and affect so many people and watching the babies die and it doesn't, you don't have to be a baby for people to care about AIDS. We should care about the gay man that gets AIDS, about the IV drug abuser that gets AIDS, because what all these diseases are teaching us is that we are all interlinked humans. And if we keep forgetting that, the microbiological world will continue to exploit and remind us about how our divisions make us weaker. And then I love what you said about allyship. I think about when somebody asks you for help, when I ask somebody for help and they come in and they just start doing their own thing and you're like, stop. I did all those steps already. I just need you to do this. I don't want you to come and take over. Please stop. Just come and do the thing I'm asking you for. And that's the same with all kinds of allyship and any work that you're doing with other people. Listen, learn where they are, find where they're asking for help. And that's the point. You come in. You don't come in and start over and recreate. With that, we're going to take a break, and then we're going to take a journey through your career and where you are now. Looking forward to it. Thank you, Nondumiso.